تمام، يلا بينا نبتدي. كده المفروض التسجيل شغال صح؟ مظبوط. طيب النهارده عندنا توبيك ظريف جدا، 3 توبيكس يعني حلوين، يعني ما فيهمش كلام كتير بصراحة. اغلبنا عارفهم يعني باي هارت، يعني الديسليبيديميا، الهايبرتنشن والهارت فيلير. اوكي، فالثلاثة ظراف جدا، ما فيهم يعني ان شاء الله هنتكلم زي ما احنا بنعمل دايما، هنتكلم على ايه يعني، نحاول نطلع الحتت المستخبية كده في كل شابتر يعني. تمام. طيب يلا بينا نبتدي. هو معانا حد هنا ما بيتكلمش عربي؟ do we have any non-Arabic speaker here? Do we all speak Arabic? طيب.
No, actually, I am not understanding what I is speaking in Arabian language. I am just
Okay, that's why I'm
trying to understand,
so no
but I am
problem.
not getting a single word. Really.
So why you didn't write anything? You could speak and say that I'm not speaking. I'm not understanding Arabic. So no problem. Okay. Uh, okay. So we are going to hold this session, excuse me, in English. No problem. Okay.
Thank you, sir.
Okay. So you are the only one, huh?
Yeah, I don't know actually Arabian a little bit even. So that's why I'm not getting you. Otherwise, I really like your like whatever you are telling. I like those explanations and all the things because already I attended one OSCE program.
Okay. I didn't get your last sentence. What is it? Just
Actually,
repeat it.
I already joined one live class of OSCE, OSC,
Yeah,
OSCE.
Post. Yes, you were.
Yeah,
Yes, you were
yeah,
with us in the last session.
yeah. That's
Okay,
why I wanted to join this one also because really these are very much informative and good for me.
okay, perfect. But are you going to take the OSCE or the MCQ one, or both?
I want to take both.
Uh-huh. In a single shot.
Trying. Yeah.
Yeah. Next May.
Yeah, May.
Okay. Good luck, my friend.
Thanks a lot, sir.
Okay. So welcome on board. No problem.
Thank you, sir. Yeah.
So it's Rashmi, correct?
Yeah, Rashmi.
Okay, Rashmi. So actually, okay, we will try to hold this session in English, no problem, because me myself, I feel more comfortable in Arabic or in French.
Oh,
But in
great.
English, okay, no problem. We have no choice, so
Great.
we can proceed in English.
Yeah.
Okay, so let's start. Today we are going to we are going to talk about 3 topics: dyslipidemia, hypertension, and heart failure.
Mm-hmm.
Okay, usually what we do usually in the MCQ session that uh, we are exposing questions, like we are yes, it's exposing questions to the others, and we are trying to solve these questions like in a similar or simultaneous manner like the real exam.
Okay.
It's not as direct as it is. It's You may find you may find some questions are tricky, and
Mm-hmm.
this is the objective of the sessions. We need to get ourselves used to the same sort of question that we were going to face in the exam.
Great.
Okay.
Wow. Wow.
Okay, so let's start. Let's proceed one by one. So my friends, if any one of you didn't get my English or have any problem in in my explanation, you can stop me and I will explain it in Arabic. قشطة يا شباب.
Yep.
طيب. Okay. So, question number 1. This is the first question, and we will talk about explain the answer afterwards. Okay, so number 1, which of the following is not among the high risk population of dyslipidemia? Okay, so we have 4 choices. Number A, a 37 years old male patient with acute kidney injury. Okay. Or a 67 years old male. Yes, it's supposed to be male patient with COPD who stopped smoking 5 years ago. Number C, 43 years old male patient suffers from erectile dysfunction. Or 27 years old female patient is being treating from HIV. So the question is, which one is not among the high risk population of dyslipidemia? So we should have here 3 out of 4 are among the high risk population of getting dyslipidemia. So it's recommended to do the screening test for dyslipidemia. While we have only one exception here. You don't have to bother yourself with dyslipidemia screening. Okay, you can rush me. You can choose your answer from the poll. You'll find like a poll here. Can you see it?
Just now I submitted the answer.
Okay, perfect. Okay, for our colleagues, Mohamed Mitwalli, you can answer on the poll. اختار الإجابة يا محمد يا متولي. طيب تمام. Okay. Okay. So we have 18 answer out of 31. We have 20 out of 31. Okay, so are you done? Okay, my friends. We are ending the poll now. Okay. The most selected answer is number D. Okay. Okay. Why you choose D? Anyone? Why did you choose number D? 27 years old female patient is being treated from HIV. Should we do the screening for dyslipidemia here or no?
Yes.
Yes, we should, correct?
Yes. Yes, we should.
So this is not the right answer, correct?
Mm-hmm.
Yes, okay. So what was your answer?
My
Sarah,
answer was A,
why?
because it's like we screen in chronic kidney failure, not in acute.
Yes, very good. And what about the GFR? 55. Should we screen here or no?
No, I don't think we should.
What about the age? 37.
No, he's pretty young.
Yes, correct. So A is the correct one, is the correct answer. As Sarah said, we screen only in chronic kidney disease, in CKD, not in AKI. Okay? So it's like a trick here. Acute kidney injury is totally different from CKD. What is the main difference between the two conditions? What is the difference? Why we shouldn't screen for acute kidney injury? Why we have to do in the CKD?
I would say that because chronic kidney disease is related to the damage of endothelial cells and blood vessels. So, on the other hand, acute injuries may be from different reasons.
Okay, so when can we say this patient has an AKI while the other one has CKD? What is the parameter we use here to differentiate between the two conditions? Is it the ultrasound? Is it the kidney size? Is it the kidney functions? Is it the time? The chronicity of injury, what is it? There is a chapter, guys, about this one, about the kidney diseases in the CTC, correct? We have a chapter dedicated to this one. Okay, so the difference between AKI and the CKD is the chronicity of the disease. If the injury happened less than 3 months, then the patient is in AKI condition. If the injury is persistent since more than 3 months, so the guy is suffering from CKD. And we usually do the screening in CKD. Why? Because some enzymes like I don't have to mention the name now because we have another question about this one, but there's some enzymes that are catabolizing or metabolizing the lipids are damaged. Okay, as Mohamed Mutwalli says, because there is endothelial cells of the kidney itself is damaged. Okay, so there will be like an accumulation of the lipids in the CKD patients, especially in the GFR less or below 60 ml per minute. Okay, below GFR below 60 ml per minute, there is a high risk of getting dyslipidemia or dyslipidemic disorder. Okay, okay, so the answer would be A. Why not B? Or why not B? Because COPD patients usually are at high risk of getting dyslipidemia. And this guy as well is an old one. He's 67 years old, so the risk is imminent here. Number C, we have 43 old patients suffer from erectile dysfunction. What about this guy? Is erectile dysfunction a risk factor to get dyslipidemia or what? Can we consider that a risk factor? At any age? Yes, correct. Okay, so yes, here, because he's a young guy and he suffers from erectile dysfunction, which is not usual at his age, so yes, we can consider dyslipidemia here. We can say that there is a strong correlation between erectile dysfunction and the cardiovascular diseases, especially the dyslipidemia. Okay, so yes, we can say this guy is suspicious to have dyslipidemic disorder. Okay, so this is the first question. Let's proceed. Second one. Is it clear from the... You have any comments? If you have any comments, please let me know at any time. Okay, so second question. Who is among the following requires initiating statin therapy? The question here is different. It could seem like similar one, but it's different here. Okay, so we are seeking about the guy who we have to initiate statin therapy here to him. Number A, 41 years old male patient who was diagnosed with CKD 1 month ago, and his ACR is 3.2 and GFR is 65. Okay, this is number one. Number two, diabetic 33 years old female patient of type 1 started insulin 10 years ago and not willing to be pregnant. Number C, 11 years old children with no documented familial hypercholesteremia, but his last LDL-C was 4.1. All of the above should initiate statin therapy. Okay, go ahead with your answers. أرميا مش باين النهارده ليه يا أرميا؟
يا دكتور مساء الخير، ازي حضرتك؟
والله تمام. أخبارك إيه أنت؟
انا تمام يا باشا، ربنا يخليك.
الحظر بدأ عندكم بقى في مونتريال ها؟
بالظبط يا باشا، انا قاعد محظور دلوقتي.
يا عم احنا بقينا 9:30. فرجت علينا شوية بين زون أورانج. تمام. اوكي. جاوب يا أرمي، أجاوب. Okay, so we have 16 answer out of 33. Yes, we have 20. Okay. The most answers is D as usual. Okay. Okay. Can any volunteer explain what is the right answer here? I can see that 5 of you answered number A and 6 number B and only 2 for number C, and D is 7. Okay, so for number C, 11 years old children with no documented familiar hyperglycemia, but his last LDL was 4.1. Should we initiate statin here or no?
I think the LDL should be more than 5 to start the statins here.
This is number 1, correct. Number 2, there should be documented familiar hypercholesteremia. Here, there is no documented familiar hypercholesteremia. Okay, so we have here, the LDL should be 5 and above. Number 2, there should be a documentation of family hypercholesteremia. Okay, so number C, we should exclude here. Okay, this is not a risk. We shouldn't initiate the statin here. Okay, number B, diabetic 33 years old female patient of type 1 started insulin 10 years ago and not willing to be pregnant. There are 6 of you answered this. Among you, answer number B as a correct one. Should we initiate statin here or no?
I think no. No.
Why, ya Zainab?
I think 15 years ago, if she has diabetes.
Is it Zainab?
Yes.
Okay. Repeat that, please.
If she has diabetes from 15 years.
Correct. Correct, my friend. If she's diagnosed with diabetes 15 years ago and more, and her age is above 30, we have to start statin here, according to Diabetes Canada guidelines. Okay, so here it's only 10 years ago. And she's above 30, okay, but she was diagnosed only 10 years ago, not 15. Okay, so number B, neither, it will not be initiated on statins. Okay, so till now we excluded 2 answers, so by default we can say that number D is excluded as well. So the only right answer that seems to be fine is number A. 41 years old male patient who was diagnosed with CKD 1 month ago, and his ACR is 3.2 and GFR 665. Okay, what are the risk factors here? We were talking about this similar case in the last questions, my friend.
The ACR is more than 3.
Yes, yeah, Amy, correct. And GFR, what do you think? What about the GFR? Is it a risk factor to dyslipidemia here?
No, I think it should be less than 60, not...
Yes, we have just said it. It should be less, GFR less than 60. Okay, ACR 3.2. ACR, what is ACR? Is albumin creatinine ratio. Okay, 3.2. This means this guy suffers from micro or macro albuminuria. What does it mean? What does ACR means? Any explanation? ACR. Is it micro or macro albuminuria?
ACR, it is the albumin to create ratio,
Correct.
and if it is above 3,
Yeah.
this guy it is eligible to statins, and here it is 41, so it is eligible because in general after above 40 it is eligible, and now it is have two criteria. It is above 40, and then albumin to create ratio is 3.2, so they have two things leads to start the statin with this guy.
Okay, correct. ACR here means this guy has a problem, has a serious problem in his kidney, because there is albumin that was excreted from his kidney. Okay, this what ACR means. This means there is a little amount of albumin that goes out of the body through the kidneys. So here, this guy is suffering from microalbuminuria. Okay, and this means this guy is a high risk of dyslipidemia. If there is a problem here. Okay, so let's see, macro 30. Yes, macro 30. It's micro, correct? Yes, it's correct. Here is the trick, my friend. Here is the trick. So we have our colleague Rima saying what? This guy was only diagnosed 1 month ago, and we have said that he should to be a CKD patient, you have to be like you have to be suffering from kidney injury 3 months, over a period of 3 months. Okay, so here is the trick, my friend. The diagnosis happened only 1 month ago, but what about the CKD? We diagnosed him with CKD. This means that this patient has a kidney injury from a long time, for a period over than 3 months. Okay, in the last questions we were differentiating between the AKI and CKD, but here this guy was diagnosed with CKD 1 month ago. This means his kidneys are injured for a period of more than 3 months. Is it clear? Because this is a trick. Okay, okay, perfect. خلي بالكم من الحركات دي. الحركات بتاعتنا دي. طيب, okay. So far so good. Let's proceed. Any questions? مين اللي بيشخبط كده يا شباب؟ Okay, so let's proceed.
Doctor, please, when I can say that is macro albuminuria? I know it is this one is micro. I know that, but
Yes.
when after what?
When the ACR is 30 and above, 30 and above, 10 folds more than this one. 30, not 3. From 3 to 30, this is microalbuminuria. Above 30, this is macroalbuminuria.
Thank you.
Okay, so let's proceed. Yes, we have case. We have a case scenario here. Type. Okay, case scenario. استنى بقى انت كمان ما تلخبطناش. Okay. Here we go. DS is 45 years old, male patient with CKD and diabetes. GFR 55. His serum creat is 1.7, has never experienced a cardiovascular event. His blood pressure is with average reading of 129/79 and no volume overload noticed recently. He drinks only 1 cup of alcohol per day, usually at night. Okay, current medication. He's taken hydrochlorothiazide 25 milligrams once daily, and you know, don't care about that. مش عارف ده ايه ده. Okay. Ramipril 5 milligrams once daily. Amlodipine 5 milligrams once daily. Insulin, Lantus 20 units at bedtime. Insulin Lispro 7 units 3 times daily before meals, without no doubt. The treating physician decided to screen DS for dyslipidemia and to calculate his Framingham risk stratification over 10 years period. Okay. Why? No, we don't need to calculate the FRS. مين اللي قال كده؟ Who said؟ مش عايزين نحسب احنا ال FRS. انت بتتكلمي على الكيسة دي؟ لا الكيسة دي ما فيش حد طالب منك. لا ما تقلقيش. احنا مش شغلتنا طبعا نحسب ال FRS. نحسبها لو هو مديك الجدول وقال لك احسبي. Okay, so this is not the case here. Okay, guys. You had all the notes. Okay, the medications, the blood
serum
pressure
creatinine here, the serum creatinine, it is 1.7. What is the normal?
less than 1. You should know it by heart, my friend. 1 or less than 1. Okay. According to the age, he's 45, so 1 or less is correct. Okay, so let's proceed. Just take the important readings, the blood pressure and the serum creatinine, GFR, medical conditions, CKD and diabetes, medications. Okay, treating physician. What's the problem here? The physician would like to screen for dyslipidemia and to calculate his Framingham risk stratification. Okay. Okay, so let's see. Question number 1. Okay, the physician asked you what the primary lipid abnormality among CKD patients would be. What mainly the CKD patients are suffering from hypercholesteremia or hypertriglyceridemia or hyperapolipoproteinemia or all of the above. You would find the answer in the CKD chapter as well in CTC. Okay. Is it hypercholesteremia? Is it hypertriglyceridemia, hyperapolipoproteinemia, or all of the above? Mm-hmm. 2014, 16, okay. Okay. Two more answers. 19, 20. يلا ها يلا 20. Okay, thank you. Okay, perfect. Okay, Number C. Okay, this is the wrong answer, my friends. This is the third consecutive wrong answer. It's not hyperabolipopproteinemia. Okay, I have the answer here and the explanation. Yes, here you go. Here you go. Dyslipidemia and CKD. Triglyceride hypertriglyceridemia is the primary lipid abnormality among CKD patients. Approximately 40 to 50% of CKD patients having fasting triglyceride levels. Okay, why hypertriglyceride is caused by because it's caused by an increased production rate and lower catabolic rate. Okay, impaired carbohydrate tolerance and enhanced hepatic flow مش عارف ايه might contribute to increased production of triglyceride lipoprotein. And this is the important part here. The reduced catabolic rate is likely caused by a decreased activity of two enzymes, lipoprotein lipase and hepatic triglyceride lipase. Okay, this is a problem that happens with the CKD patients with the kidney damage. We have two enzymes here that would reduce or damage. The most important of them are hepatic triglyceride lipase, okay, which cleave triglyceride into free fatty acids for energy production and storage. Okay, so triglyceride hypertriglyceridemia is the primary dyslipidemia abnormality in CKD patient, and this information is very important. Okay, you have to mark it. It's very important. Okay, so second questions. Here we go. DS blood pressure reading is, oh yes, should be reduced. Blood target, excuse me, it should be here. DS blood pressure target should be reduced to 120, the systolic blood pressure, or it's already within the target value because he's diabetic, so the value should be that, or can be increased to target below 135/85 in order to avoid hypotension. Okay, or A and B. We have three target values here. Is the blood pressure, what was the reading? The reading was, yes, here you go. His blood pressure reading was 120/79. And now we would like to know, is it within target? Is it out of the target? Okay. Okay, so we are done. Oh, go. You were about to answer this question correctly, but you refused to do, my friend. No, this is not the right answer. This is not the right answer. Okay. Why? Okay, nine among you answered A, which is the correct one. Why A is the correct answer? Why? And it's not B.
Because he is a high risk patient, doctor.
Why? Why would you say that?
High risk.
What I know for the high risk patient, if the patient is like I think there's like 3 or 4 conditions if he's more than 75 years, but the patient here is not.
Okay.
And the Framingham score is more than 15%.
Do we have the
And we don't
Framingham
have
score
the,
here?
no.
Okay.
And
So while
yeah, and cardiovascular diseases and chronic kidney disease.
yes,
So I need to go back to look to the case if you want me to give you the reason.
you answered it.
Yes, it's
Was
one
it
of
diabetic? Yes, he's diabetic and CKD patient. CKD patient. So the target should be below, systolic should be below 120. This is correct. It's not here. He's diabetic, yes, but he's CKD. Okay, so the predominance here goes to the CKD. Okay, so we have to control the blood pressure more than that. It should be below 120. Okay, what is the reference? The reference here, you have so many reference for that. The CTC, you can find it, the CTC, you can find it in the Sprint trial. There is a very famous trial called Sprint. And this criteria, by the way, it's called Sprint criteria. Okay. No, according to CTC, it's for the diabetes, my friend. This target is for diabetes. But what if the patient is a high-risk patient, like the CKD patients? You will find it clearly stated in the CTC. Yes, bravo, Anage. Hey, Sprint criteria. Okay. Okay, so hold on, my friend.
Doctor,
Which chapter? In the hypertension. It's in the hypertension. I think I have it here. Okay, so let me check it. Yes, here it is. It's hypertension. Okay, here it is, my friend. Here it is. Okay, high risk, also known as Sprint criteria, includes 75 years old age, presence of clinical or subclinical cardiovascular disease, or chronic kidney disease, or estimated Framingham score over the more than 15. Okay, so high risk, what is the target for high risk population? Here you have, yes, it's here. High risk of cardiovascular event. What is the target? It should be the systolic blood pressure should be below 120. And this is the CTC. Okay, hypertension. And even up to date says the same thing. Okay, is it clear? Okay, Bisha. Okay, perfect. Let's proceed, my friends. So the target should be 120 systolic blood pressure. Okay, question number 3. What are the best initial therapeutic approach for the S-Probable dyslipidemia disorder? Okay, what we should do? Should we initiate statins at moderate dose? Should we initiate statin at high dose? Or high dose plus aspirin? Or should we initiate fenofibrate at the normal dose? Or should we initiate fenofibrate plus cholestyramine? Attention, guys. It's entrapment, okay? في فخ.
Can I know the patient age, doctor?
ايه؟
الage بتاع البيشنت.
الage 45 كام الاتش كان كام نسيت والله. 45 yes. It's 45. CKD and diabetes. Okay, here we go. We have 11 answers till now. Turn it 14, turn it 15, 16, 17. Yes, 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 yes. 18. Huh? 20. Yalla. 22. Pooh. Okay. So we have number A. We should initiate statins at moderate dose. Okay, I told you there is a trap here. Okay. Okay, so what do you think? What we said about the dyslipidemia disorder in CKD patients? What is the most dyslipidemic abnormality? Is it hypercholesteremia? Is it hypertriglyceridemia? Is it hyperapolipoproteinemia? Which
Sir,
one?
can I answer?
Yes, my friend, go ahead.
Okay, the answer, I think the answer it is C. It is cinefibrate. Why?
Why?
Because this is, you ask in the question, what is the initial? So the initial here, I have to target the hypertriglyceridemia for this patient. For this patient is CKD. And the first thing, it is the TG for this patient is supposed to be over 200. Okay, so I give the fibrates here to lower the initial TG. That's it.
Okay, because you believe that this patient most probably he will be suffering from triglyceridemia, correct?
As initial.
Yes, okay, I know. Yes,
Yes,
yeah.
okay.
Okay, so he's diabetic. So C. Rima, no. Actually, guys, the correct answer is A, as you said. It's not C, Armia. And this is a trap. Okay. Yes. Because here a few minutes ago, I was talking about what? I'm telling you that the most important, the most common abnormality in dyslipidemia in CKD patients is the high triglycerides, correct? So you should, not many of you actually answered number C based on this information, I believe. Okay, but this is not correct. We here in triglyceridemia, okay, what we do in CKD patients with high triglyceridemia, that we treated it with non-pharmacological approach, unless the triglycerides is above 800 or something like that. Yes, about 800, then we can start a treatment. Why we cannot start, or it's not recommended to start a treatment with fenofibrates here? Why? Any clues? Any clues? And why should we start statins? So what's the problem, Elsayyad, in CKD? Yes, we know. This guy is CKD patient, so it's first line. Statin.
Yeah, I think this patient is a statin indicated condition.
Yes, correct. He's diabetic. His age is
Yep.
above 40 years old, correct? And he's in high risk of cardiovascular events, simply speaking. What about triglyceride? Is triglyceride mainly correlated to a major event of cardiovascular disease? is triglyceride mainly related to a major risk of cardiovascular, or is it the cholesterol? Phenofibrates mainly treat the triglyceride, correct? And triglycerides, what is the main problem of triglyceride? If the triglycerides went so high, what is the problem? Will it cause, will this will lead to a cardiovascular event like like acute coronary syndrome, for example? No, mainly it will lead to what? A very high triglyceride level will lead to what? What's the problem? Yes, yeah.
Pancreatitis.
Yes.
Pancreatitis.
Yes, pancreatitis. الله يفتح عليك. انت ورانا وريما كمان. Okay? So pancreatitis. The problem here is the cholesterol. It's the main correlator to the major cardiovascular events. And this guy is diabetic. His age is above 40. So what you have to do, you have to start statins at once. Why it's moderate dose? Why shouldn't start it at high dose? Why it's moderate and not high? Okay.
I think no previous cardiovascular event.
الله ينور عليك يا ناجح يا مذاكر يا مذاكر انت. Yes, عشان there is no history of cardiovascular event. So you can start him, you can put him in moderate dose. No need to put him in high dose. High dose usually in secondary prevention, we use a high dose of statins. Okay, number one. Number two, why we shouldn't initiate phenofibrates in CKD patients to treat to treat triglycerides, high triglyceride. Why it's not recommended? It's recommended only if triglyceride is above 800. Okay, if it's above 800 or 10 millimole per liter, so there is a high risk of getting pancreatitis. And phenofibrates is usually, it's not recommended in renal diseases. Do you remember this information?
Again, please, sir. Again, please.
Phenofibrates is not recommended in renal diseases.
No, about the number, about the TG above what?
Yes,
above 800?
TG, yes, 800 milligram per DL equals 10 millimole per liter, and above 10 millimole per liter, there is a high risk of getting pancreatitis. This is where we should initiate the pharmacological treatment of triglycerides in CKD patients. If it's below that, so we can go only for non-pharmacological measures to treat triglyceride in CKD patients. Why? Because phenofibrates, which is the main drug of choice to treat triglyceride, is not recommended in nephropathy. If there is renal impairment and it's stated clearly in CTC, you should adjust the dose. Okay? This is why it's not recommended to initiate phenofibrate to treat triglycerides in CKD patients, despite the fact that triglyceride is the major dyslipidemia abnormality in CKD. Is it clear?
يعني السؤال يعني إذا جليسيريد أقل من 10 بهي الحالة بس بحالة الرينال ديزيز نلجأ للنون فارما ولا بشكل عام؟
Yes, بتلجأ للنون فارما.
بس بحالة الرينال ديزيز؟
في حالة الرينال ديزيز, yes.
اوكي, بس in general?
In general, لا, you can start if there is no
we can start.
Yes, if normal patient has only high triglyceride, no, you can start phenofibrate.
Okay.
No problem, of course, yeah. Okay, so perfect. So is it clear, my friends? So statins to decrease the cardiovascular event. Okay, let's proceed.
Excuse me. What about option B? When do we usually initiate a high dose of statins plus aspirin?
Yes, we have just mentioned that, Emmy. It's in the secondary prevention of cardiovascular.
Okay, got you. Thank you.
Okay, here we are talking about primary prevention because in the scenario it's stated that there is no previous cardiovascular event. Okay, question number 4. After calculating the FRS, Framingham risk score for DS is the name of the patient, okay? The physician told you that the score turned out to be 17, risk over 10 years. He contacted you to get recent recommendation to modify the therapeutic plan of DS in order to reduce the risk of having major cardiovascular event. What would you recommend? Number A, niacin lowers triglyceride levels and increases serum HDL level in CKD patients that may reduce major cardiovascular event incidence if used with statins. Okay. Number B, management of LDL to reduce cardiovascular risk in patients with non-dialysis CKD differs than normal population. Number C, combining simvastatin with ezetimibe will significantly reduce the risk of major atherosclerotic and vascular event in DS case. Number D, non-pharmacological approach to hypertriglyceridemia management is main approach in CKD patients to bring triglyceride level below 200 and to reduce MACE. يلا بينا. Rashmi, are you still here?
Yes, sir. I'm here only.
Okay, because
I'm participating. Yeah.
okay.
Thank you.
Okay, guys, we need more answers. It's a very simple one, by the way. It's not that tricky. Yeah. 14, 15. جاوب يا أرمي يلا. 18, 19. Okay, 20. Okay. 21. Okay, guys. Okay, this is really pleasing. Okay, hello. This is the second consecutive question that you answer correctly. Okay, simvastatin plus ezetimibe will significantly reduce the risk of major cardiovascular event in any CKD patient. Okay, ezetimibe plus simvastatin is superior than statins alone in CKD patient in terms of reducing the major cardiovascular event. And this is the correct answer. There is no benefit from niacin to reduce the cardiovascular event. No benefit at all. Here, number B, management of LDL to reduce cardiovascular event is the same in CKD like normal population. There is no difference because the statins, most of them are eliminated hepatically, not renally. So they are safe in cardio and in renal diseases. Okay, so here there is no difference between the normal population and the renal population. Okay, number D, yes, non-pharmacological approach to hypertriglyceridemia. Yes, this is the first choice. is the main approach in CKD patient correct to bring triangular and to reduce MACE? Till this word, till 20 milligram, 200 milligrams per DL, the sentences is correct. But to reduce major cardiovascular event, no. No. There is no benefit from reducing hypertriglyceridemia in terms of preventing or reducing the MACE, major cardiovascular event. Okay? So C is the correct answer. Type. Let's proceed. Is it clear? Any questions? Any comments? Okay. 5. Okay, so this guy, routine monitoring parameters for this patient will be all except ALT, which is liver function, serum creatinine, which is kidney function, creatinine kinase, which is muscle protein, LDL, which is lipid profile. We should do routine monitoring for all of these 4 tests except one. One is it? Okay, 15, 16, 17, 18, 19, 20, 21. Are you done? Are you done? واحد كمان يلا. Okay. Okay, fine. Okay. Okay, what do you think? The first C, why C? With statins or ezetimibe, should we do the creatine kinase test or no? So this guys, recently in the last questions, we have added the statins and ezetimibe to his medications, correct? And he has already taken hydrochlorothiazides and ramipril and etc. and insulins and the other medications and amlodipine. Okay, so creatinase, should we use it to monitor routinely the CKD patients with for the statins and ezetimibe or no? You answered C. Why C? Which means we don't have to do routinely the creatine kinase test. Okay, we have Summer here is telling us only if patient get muscle pain, not routinely. 100% correct. صح. No, Yarima, we don't we don't have to. No. Only if the patient suffers myalgia or muscle pain, we can do the creatine kinase. But with the other test, we have to do it routinely. For the liver, yes, you have to do it because the patient is going to take the simvastatin and ezetimibe, and both may cause elevation in liver enzymes. Okay, serum creatinine, of course, you have to do it because the patient is CKD patient. I wonder why 7 of you answered B. This is a CKD patient, guys. He should every month, I think. He should do the serum creat test. Okay. LDL, of course, you have to do it as well. Every 3 months. Every 3 months during the first year, you have to do the LDL. Okay. Is it clear? We have to, if mentioned in, it mentioned in CTC, high risk patient, and best virus. No, if you, no. You have to do creat kinase if the patient suffers from myalgia or muscle pain. If there is no muscle pain, why would you do the creat kinase? What is the benefit? The first sign of muscle-related symptoms resulting from the statin treatment is the muscle pain. If there is no pain, there is no problem. Correct? No. It's not routine. Yes, you can do it you can use it during the statin therapy, but it's not routinely done. If there is no pain, so no test needed. Okay, is it clear? Yes, it's mentioned here, routine monitoring. Okay, let's proceed. Question number 6 of this case. Here we go. Few weeks later, the patient complains from muscle pain all over his body. This is all. After undergoing clinical investigations, the physician told you it's due to myalgia that was suspected from statin therapy. All of the following are predisposing risk factors to develop such muscle-related symptoms, except, which are the risk factors here? Except, excuse me, which is not the risk factor. Is it the amlodipine? Is it the hydrochlorothiazide? Or his GFR? Or alcohol intake? He takes 1 cup of alcohol. His GFR is 55. Yes, as I remember. Hydrochlorothiazide 25, amlodipine 5 milligrams. Which one would not be a risk factor for muscle-related symptoms from statin therapy? Okay. 15, 16. 17. 20. Okay. Here we go. Number A. You answered A, amlodipine is not a risk factor. It is a risk factor. Why it is a risk factor? Amlodipine. By the way, the correct answer is B. Hydrochlorothiazide is not a risk factor. It's the only not risk factor in the answers, in the options here. Okay. Okay, GFR, the kidney disease, chronic kidney disease, is a risk factor to develop muscle-related symptoms with statins. Alcohol intake as well is a risk factor to develop muscle-related symptoms with statins. Hydrochlorothiazide, it's not a risk factor to develop muscle-related symptoms. Amlodipine, it is. Okay, so amlodipine is as well a risk factor. Why? Any answer? Any comment? Why amlodipine is a risk factor? Yes. All calcium channel blockers, my friend. Okay. Either non-dihydropyridine or dihydropyridine inhibit the liver enzyme, the 3A4 enzyme. Okay. The amlodipine, the verapamil, nifedipine, all of them, dihydropyridines and non-dihydropyridines are enzyme 3A4 inhibitors. Okay. And what the patient is taking what? He's taking simvastatin. Simvastatin is the same like atorvastatin. Simvastatin, lovastatin, atorvastatin, they are metabolized by 3A4. Okay, simvastatin, lovastatin, atorvastatin, they are metabolized by 3A4. Okay, so non-dihydro? No. No, it's old. It's mentioned, by the way, it's mentioned elsewhere in the CTC that all calcium channel blockers are 3A4 inhibitors. I remember this information very well. Okay.
Sir, please, which statin again? Sam and Atur and what?
Lovastatin, simvastatin, atorvastatin.
This only metabolized by cytochrome 3A4, E4, and the
Yes.
other no?
Yes. What about the others? Do you have any idea? What about rosuvastatin and fluvastatin and pravastatin? Yes, rosuvastatin 2C9. Yes, correct. Rosuvastatin and fluvastatin 2C9. Pravastatin is not metabolized by liver enzymes.
Rosuva, what it is? What it is?
Rosuva and fluvastatin.
Okay.
2C9.
El Parava بقى? No.
No. So if we say, Armia, if we say that a patient is drinking grapefruit juice, so he should be cautious with which statin.
Cytochrome 3A4.
Yes, correct. And so he can safely take the rosuvastatin, for example.
And the fluvastatin, yeah. And warfarin, by the way, because it is metabolized by cytochrome 2C19. So the grapefruit not act about cytochrome 2C9 or C19.
Yes, my friend, correct. Okay, guys, so it's clear. Let's proceed. Here we go. Yes, this is for your reading. You can read it here. Dyslipidemia in CKD and moderate intensity statin doses that has shown benefit in CKD patients like atorvastatin 20, fluvastatin 80, pravastatin. This is a moderate doses of statins. Okay, it's like some important hints. Just read it. It will be beneficial to you. We typically don't use fibrates. Here it is. We typically don't use fibrates as they are more likely to produce side effects, particularly when given with statins. However, rare CKD patients who have serum triglyceride, here it is, 10 millimole. Above this reading, there is a high risk of pancreatitis. Okay, my friends. And here's niacin, also lowers serum triglyceride levels and increase serum triglyceride. Okay, we mentioned all of this information. So far so good. Okay. Sorry. Okay, let's take one question. It's an easy one, I think. Here's one. It's a simple question. Okay, which one of the following medication may not cause secondary dyslipidemia? It's acebutol, prednisolone, estradiol, indapamide. Which one? Secondary dyslipidemia may not cause secondary dyslipidemia. Hmm. 15, 16, 17. ده عشان اللغة والله. It's language. ده عشان اللغة بس. مش عشان أمريكا. اوكي. لا، احنا في كندا ما فيش عداوة ولا حاجة. احنا في كندا جنب أمريكا على طول. طيب اوكي. So okay, let's end the poll. We have here number A. Okay, it should be an easy one, guys. Okay, why there's 10 why 10 of you selected number D? Why you choose that? It's I don't know why. Okay, so the first answer. Okay, okay. The majority of you went with acebutol. It's a beta blocker, correct? Beta
But
blocker.
it's intrinsic.
Yeah.
Sir, how acetobutol it is beta blocker?
Acetobutol
sorry. It is a beta blocker with intrinsic activity, so it is not don't cause hyperlipidemia.
Yes, correct. That's it.
Yes.
That's the answer. Okay. Indapamide is a thiazide diuretic. Thiazide diuretics may cause some dyslipidemic disturbance. Okay. So thiazide, they cause disturbance in the dyslipidemia. So the answer would be acebutolol. It's beta blocker, correct, but it is with intrinsic sympathomimetic effect activity. Okay. Okay. Dyslipidemia screening, yes, it's like information. Screening of lipid profile is recommended in children. Here it is with a family history of dyslipidemia, men or women above 40 years old. And for South Asians and First Nations as well, they are high risk here. Okay, and screening should be done at earlier age for First Nations and South Asian people. Okay. Okay, sample questions as well. It's like a break question, you know. African American? No, I don't know. Are they high risk? I think they are high risk, correct? They're high risk as well for dyslipidemia, huh? I don't know. مش عارف, I don't know. ممكن, yes, hypertension. I don't know for dyslipidemia, they're high risk or what. Okay, so okay, our question. Let's start the lunch. all of the following agents could show benefit in reducing major cardiovascular events, except it's very easy. Huh? Simvastatin, gefimprozole, ezetimibe, evocolumab. Okay. 15. Which one is not having any major effect or prevention on cardiovascular event? 17. عايزين 3 كمان. 3 more answers. 3 more answers. 18. 19. 20. Okay. Well, guys, what we say, what we have said a few minutes ago. We said what? What is... Why you are so forgetful? You're forgetting so quickly. Okay. What is the answer? What's the correct one? It's B يا أرميا. طب ما جاوبتش ليه يا أرميا B?
Yes, sir. I'll just answer now. It's B.
Okay, it's
because
B.
Because the monoclonal antibodies with the evocolumab, it is for the familial hyperdyslipidemia for the kids, for what they have this
What
category.
is it? Which one?
The last one is the evocolumab.
Okay.
It is used.
Does it have a major benefit on the major cardiovascular event or no? Evocolumab.
Yes, it is have.
Yes, it has. It
Yes.
has. Because
Yes.
it mainly treats the cholesterol. It's the highest. Yes, it's the highest hypocholesteremic agent. It is the highest.
The only one it is gimifibrosil.
Yes, gimifibrosil is the only one that targets what? That targets the
targets the
triglycerides.
TG. It is fibrates only.
Yes, and there is no benefit approved in any clinical trial that gefimprozil can reduce major cardiovascular event. Simvastatin, of course, it will reduce. Ezetimibe, of course, it will reduce in certain conditions. Like what? Like in CKD patients, as we said. In combination, ezetimibe in combination with simvastatin in CKD patients, there will be a benefit to reduce a major cardiovascular event. Okay? Is it clear? Okay. So it's clear. Here it is. Ezetimibe effect on cardiovascular event. Yes, there is a benefit, of course. As we said, in chronic kidney disease, combination of simvastatin significantly and safely reduce the risk of major atherosclerosis. Okay. Yes, here it is some benefits of the ezetimibe. Didn't show improvement in patient-related outcomes such as, no, it's, yes, in specific situations only, on specific scenarios only, like CKD patients. Okay, it's better tolerated than resins. Okay, so here we have some miscellaneous questions that should, it's like, you know, it's like brainstorming questions. Okay. We have some brainstorming questions, some definitions that you should be aware of. that you may face in the exam. You may have it in a case. You never know. Okay. So, definition of premature CVD. What is premature CVD? Definition. What does it mean?
It's cardiovascular in male before 55 age and the female 65 age.
In male, 55 and female 65, correct?
Yeah, in first degree relatively.
Yes, correct. In first degree relatives. بالظبط كده. Exactly. When we can say this guy has a premature cardiovascular disease, when he's a male younger than 55 or a female younger than 65. Because you know, males are usually in a higher risk of cardiovascular disease than females. Okay, so if there is a patient that yes, correct يا ريما 55 و 56 55 and 65, yes. Okay, so this is a risk factor. This is what we mean by premature cardiovascular disease. Okay, and if the patient has a first degree relative, like his father, his mother, his brother, for example, or his son, maybe. So this means this guy is a higher risk of a cardiovascular disease, and we should screen him prematurely than the others, earlier than the others. Okay, so the PEX9 inhibitors like Repata is very famous medication here, which is evolocumab. Dosing and dosage form. Okay, so the Repata and evolocumab, for what reason we use it usually? For triglycerides, for cholesterol, or high HDL. We use it usually for what reason? The evolocumab or the Repata?
LDL.
Okay, what about its effect on HDL and triglycerides? Does it have a major effect or very minor effect?
Minor.
It has no effect on triglyceride and HDL.
Yes, it has no effect. Only the cholesterol, only the LDL. Okay. Okay, it comes in what? In tablet, in sachets, in injection, in solutions? What form?
Subcutaneous.
Yes, injections, subcutaneous injections. Okay, do you know the dosing? Should we use it every day, every month, every week, every hour? Are you aware about that? Yes, correct, Maria. Yes, usually we use it every 2 to 4 weeks. According to the dose for the Repata, if we are using the 140, I think we use it every 2 weeks. If we are using the 420, 420, we use it every month. Okay, so this is the Repata. So usually it's bi-weekly. Okay, it's bi-weekly dosing and it's injection. Okay, rosuvastatin initial dose in Asian and in patient taking cyclosporin. There is special dosing for rosuvastatin in Asians and patient taking cyclosporin.
5 milligram per day.
انت جاي مذاكر يا عم بقى وفاضلنا بقى. جاي فاضلنا بقى انت عم ناجح. Yes, it's 5 milligram.
لا بس سمعتوا المحاضرة انت سجلتها قبل كده، بس ده كل اللي عملته يعني.
والله طيب ماشي. هلغي لك انا المحاضرات دي خالص. ايش ناجح الله ينور. Okay, rosuvastatin initial dose in Asian and patient taking cyclosporin, it's 5 milligrams. Okay, we usually start use of a statin usually we start with 10. And atorvastatin usually we start with what? With which dose? Atorvastatin. Should we titrate, guys? Should we titrate the statins or no need to titration? Is it yes, but do we need to titrate the statin? It's not like, it's not a central nervous system. Ziad saying no need. Yes, I don't think. Urima كمان. She's okay. We have Aline. Okay, Aline, Urana, Rashmi are saying yes, we need to titrate. Yes, we need to titrate the statins. We need to titrate. Okay. You start with the initial dose and you increase gradually. Every week you can use a higher dose, or maybe less than every week, by the way. You can titrate it, I think, every 4 days or something, 3 to 4 days. Okay. But usually most of, yes, go ahead.
Is the titration required to monitor the cardiac toxicity with statins?
Not cardiac, it's hepatic toxicity.
Sorry, I mean the myotoxicity.
And
The
usually
muscle toxicity. What's the point of titration with the statins?
Yes. First of all, there are some physicians that use statins for at least 1 month or something to say the LDL, its effect on the LDL. If it's within target after 1 month or 6 weeks, they continue with this dose. If the target is not attained, they will increase it to the higher level. Like if we start with atorvastatin 10, usually 10, by the way, is not like it's not like the optimal therapeutic dose of atorvastatin. Okay, the optimal therapeutic dose for atorvastatin is from 20 to 40. From 20 to 40, this is the optimal therapeutic dose of atorvastatin, for example. So there is no patient, there is very rare or few patients that are using 10 milligrams. Okay, so the doctor start to first, the most important is the LDL level. If it's controlled with the dose, so we will remain with that. If it's not, we will increase the dose and see what will happen. Okay, this is number one. They are not considered the muscle myotoxicity of statins unless there is a high risk. Like in a CKD patient, for example, if the patients are taken one or more than one 3A4 inhibitors, for example, or medication that may cause serum increase in statin level, for example. If there is like a drug interaction, if the patient is too old, is very and have so many problems, health conditions, etc. You know, there is a list of predisposing factor for the statin myotoxicity. If there is so many risk factors, so the doctor will consider this side effect. If not, so there is no need. By the way, guys, the risk of muscle-related symptoms with statin is not that common, okay? It's not so common. Myalgia it happens only from 10 to 20% of the populations, of the people who are taking statin, moderate to high dose statins. Myalgia. Myositis or rhabdomyolysis happens in about 2% of the patients who are taking the moderate to high doses of statins. So they are not so common. Okay? That's why we are not following on a routine basis the CK is a creatine kinase. Okay, is it clear? واضحة دكتور أيمي؟
يا دكتور شكرا.
Doctor, please, you said that I know it is the starting dose of rosuvastatin with cyclosporines. It is 5 milligram. But here you ask also for the ASEAN. If it is an ASEAN people, don't take cyclosporine. Take also 5 milligram.
مش فاهم. I didn't get your point.
طيب انا عارف ان الروزفستاتين بتاخد 5 مللي مع السايكلوسبورين.
اوكي
مع الناس الاسيويين الاسيان
اوكي
بتوع اسيا برضه 5 مللي حتى لو ما كانش بياخد سايكلوسبورين.
yes
okay
with Asian people. It's as per the CTC. Okay, so perfect. I am Russia, I think. Yes, Ellen, ماشي يا دكتورة رشا. All cardiovascular drugs need titration. Yes, most of them. Correct. Most of them. They need titration. Okay. myopathy. طب دكتور ايه أعلى شيء ممكن يسبب myopathy? What do you mean? The dose? Usually, yes. For atorvastatin, the highest dose is 80. High dose, the risk of myopathy is correlated to the dose of the statins. The higher the dose, the higher the risk. Okay? The higher the dose, the higher the risk with the statin type. Okay.
Doctor, please, can I add something and correct me if I am wrong? Because I read it from couple of days. With cyclosporine, with patient with cyclosporine, there is 3 statins used with cyclosporine: rosuvastatin, pravastatin, and the atorvastatin.
Atorvastatin. Okay.
Yes, that's it.
Yes, could be. Okay. Thank you so much, my friend.
Thank you.
Okay, next. At what interval Framingham risk score should be performed in patient above 40 years old? Okay, every how many years we should repeat the Framingham risk score? Every year, every 2, 3, 4, 5, 6, 7, 8. At what interval, guys? How many years? What's the problem?
10 years.
هو عشان 10 years فانت هتعمله كل 10 years.
بالظبط.
No, not 10 nor 3. Yes, Leah Coselli, 5. You are guessing, huh? It's like you took a guess, but yes, it's correct. It's 5 years. Yes, every 5 years we repeat the Framingham risk stratification test. Okay, what is the difference between modified? This one is very important. What is the risk between the modified Framingham risk score and regular Framingham risk score? I think Nagah will answer here.
لو if we have a family history من ال premature cardiovascular disease we double the risk score, so this is called modified after double.
Yes, correct. If there is a patient, if the patient has a premature cardiovascular disease history, family history of premature cardiovascular disease, we calculate the Framingham score, and at the end we multiply it by 2. We double it. If the score is 5, for example, we make it 10. Okay, so here we converted it from the regular Framingham score to modified Framingham score. Okay, when premature cardiovascular first degree patient. Yes, Mariam, correct. Okay, so statins with highest risk of muscle related symptoms. Which ones? Which statins? with highest risk of muscle-related symptoms?
Number one, it is rosuvastatin.
طيب. You killed me, my friend.
No, I'm sorry.
Rosuvastatin is the highest risk. Ay. You
I
killed me.
know.
You give me no. You got me like a major cardiovascular event.
بعد الشر عليك. احنا محتاجينك.
Yes, atorvastatin, simvastatin. Yes. What is the rule here? What is the norm? Is there a rule here? We can say this guys are causing the most side effects while the other guys are not causing the muscle related symptoms. What we can say. Okay. So guys, usually the statins that are causing the most drug interactions are the one with the most muscle related symptoms. This means the statins which are more deeply involved in enzyme inhibition and enzyme metabolism, hepatic enzyme metabolism, they will be related the most with the muscle related symptoms. And here we are talking about the atorvastatin, simvastatin, okay, and lovastatin. They are the most. Rosuvastatin, yes, but it's less to a less extent than the other ones. Flavastatin and pravastatin are the lead. Pravastatin ده انا صح؟ انا بسمع صوتي تاني ليه؟ بيعمل ميوت. Okay, so pravastatin and flavastatin are the least, while atorvastatin, simvastatin, lovastatin are the most. Moderate rosuvastatin is the moderate one. Okay? Yes. في واحد بيسجل، مش عارف بتسجل ليه؟ هي المكالمة هي البتاع متسجلة أصلا يا دكتور أو يا دكتورة. Okay. طيب. So this is statins with the highest risk of muscle related symptoms. Clear؟ مهمة دي. يبقى الروزوفاستاتين تاني أقل واحد. The least is the flavastatin and pravastatin. Okay, what about the alternate day dosing of statins? What is it? Have you ever heard about that? When it is preferred for which agents? Have you ever heard about alternate day dosing of statins? I saw it once or twice in the pharmacy. The doctor are prescribing alternate dosing of statins. What does it mean? It means that the patient take one day and for the other day has not taken it. In alternance, on alternance. بياخد يوم وبيسيب يوم. Every other day. Okay? This is what we mean by alternate day dosing of statins. Have you ever heard that? Can you guess for what reason we can use that and for which agents? And we have it could be the same answer like the below questions with which statins you can take in the morning, or we should always take the statins at night. Can we take some statins in the morning, or we always should take it at night?
Sir, can I answer?
Yeah, Yunus Sir, the eyes of
Yeah,
the Sir.
merci. All the statin taken at the morning except rosuvastatin and atorvastatin may be taken at night.
Another major cardiovascular event. Next, you will get me a stroke, my friend. No,
كله ممكن كله بيتاخد الصبح ما عدا الرزوفه والقطور بيتاخدوا بالليل، ممكن يتاخدوا بالليل.
انت عكست.
اوكي يس انت
ما
عكست.
انا قلت كده في الاول على فكره.
لا ما انت قلتش كده، انت قلت العكس. انت قلت الاتورفاستاتين، انت قلت كله بيتاخد الصبح. you said
كله
that
بيتاخد.
all-
لا no. I said that all the statins taken at the morning except rosuvastatin
yes,
and atorvastatin can be taken at night. Why? Because they have long T halves. Okay, that's it.
No, my friend. Yeah, it's the opposite. All the statins, they preferably should be taken at night, while atorvastatin and rosuvastatin can take it at the morning or any time of the day. Why? Any answer?
الانزيم
What do you mean by enzyme?
الانزيم اللي هو convert
HMG reductase?
دكتور عشان
yes
يمكن
yeah this usually working in the night.
Yeah, this is one answer. Okay, في دكتورة كانت بتجاوب.
مساء الخير دكتور.
كيفك؟
الحمد لله. أعتقد مشان لأنه نوزيا يعمل فهو ياخذوه بالليل.
لا no.
طبعا من
Yeah.
الميوت.
It's usually like ناجح said, because the HMG co-reductase enzyme usually, okay, it's highly active at night. Okay, it's highly active at night. That's why we are taking the short-acting statins at night. Because if you take them at the morning, they only have a half-life of 6 hours in average. Okay, if you take it at the morning, so you will come at afternoon, there will be no effect of this statin. Okay, so they only have like a half of 6 hours, while atorvastatin and rosuvastatin, they are long-acting statins. Their half-life is about 14 or 15 hours.
الروزوفاستاتين I think 19 والأتروفاستاتين يمكن 16.
Yes, maybe, yes, something like that. So they are long-acting statins. So you can, even if you take them at the morning, they will be still be active at night as well. So they will act at the enzyme.
يعني الانزيم ال HM CoA reductase بيشتغل بالليل بس؟
Yes, مش بالليل, he's active all the day, but the highest activity is at night. Okay. That's why you took usually the statins, the short-acting ones like the simvastatin and fluvastatin, etc., at the night. The only one that you can take in the morning or every day or any time of the day are rosuvastatin, atorvastatin, Lescol XL, which is fluvastatin XL. Okay, because it has a long half-life as well. It's about 20 hours or something. So the Lescol XL, which is fluvastatin XL, the extended release, and atorvastatin and rosuvastatin, 3 of them could be taken at any time of the day, while the short-acting should be taken at night. Okay, if you take it at the morning, their effectiveness will be highly reduced. Okay.
Pravastatin also, I think, at any time.
Pravastatin, I think it's short-acting. ناجح برضه.
No. The lovastatin we have short-acting and we have extended release.
Yes, and fluvastatin, we have the same.
Fluvastatin is the same, yeah, the same. Intermediate in the night, long-acting at any time.
Yes, pravastatin. Yes, I think it's if you are sure it's long-acting, so it will be.
Yeah. Pravastatin at any time.
Okay.
But simvastatin usually in the night.
No, simvastatin, yes, of course, it's at night. Okay, so Here is the answer of this one. Okay, let's get back to the alternate dosing of statins. What does it mean? Alternate dosing of statin if the patient has myalgia. Okay, if the patient has myalgia or any symptoms, instead of stopping the statins, the doctor would go the alternate day dosing of statins. It's usually used with the long-acting statins as well. We don't use it with the short-acting. Okay. Why it's preferred? It's preferred because usually it gives the same LDL effect, reduction effect, the same effectiveness with the everyday dosing with reduced side effect. Okay, so the side effect, it's more definitely more tolerable than the everyday dosing, and at the same time it gives the same effectiveness the same effectiveness of the everyday dosing. That's why some doctors go for the alternate day dosing of statins. Okay. Last question.
Sir, please, this in the case of a patient with myalgia, البيز لاين بتاعه myalgia يعني هو جاي عنده
Yes.
myalgia وانا لازم اديله statin.
If he's taken, no, he was already, no, it's not like that. If the patient developed myalgia with the statins, I said instead of stopping statins, you can go with a trial with him with alternate day dosing of statins.
وبدي لونج اكتنج زي القطور او الرزوق.
Yes, correct. Okay. So last questions to proceed. Statins, ezetimibe, fibrate monitoring, contraindication. Quickly, in 1 minute. Monitoring for what are the contraindication? Let's get rid of the monitoring. Okay, what about the contraindications? Statins and fibrates. What are the contraindications? Quickly, my friends. Quickly.
liver disease.
Liver disease?
Yes, أعتقد.
What else? Okay. We have liver disease and pregnancy and alcohol intake. This is for statin and ezetimibe. Ezetimibe is fine with the pregnancy, I think. No, it's not fine as well. Yes, renal dysfunction for fibrates, gallbladder with fibrates, and liver disease with fibrates. So we have three for both statins, alcohol intake, liver disease, pregnancy. Okay. For fibrates, kidney disease, liver disease, gallbladder disease. Okay. Okay.
Can you repeat, please, sir?
Okay, I will repeat.
liver,
Yes.
kidney, and the gallbladder. It is okay for the statin and the fibrates.
Alcohol.
Yes.
Alcohol for statins. It's alcohol,
yes.
liver disease, and pregnancy.
And the pregnancy?
Yes.
For both statin and fibrate. Huh?
No, it's only for statins. For fibrates, it's gallbladder disease, renal
kidney,
disease, and kidney liver disease.
And for the ezetimibe?
Ezetimibe is liver disease.
Yes.
And alcohol consumption.
Okay. Thank you.
Okay. This is alternate day dosing, guys. You have some words here, some notes. Okay, and here is a note about statin times. Which one in the morning, which one in the night? Liscol, fluvastatin, here it is. Okay. Okay, we have case scenario. Are you ready? Are you ready?
And sir, and the monitoring is CK. It's okay.
Yeah, Basha.
And the monitoring, it is the CK.
CK is not routine if the patient develop myalgia.
Yes.
For monitoring, for statins, we use the liver and LDL and the liver function and LDL and CK if the patient develop myalgia. For phenofibrates, it's renal, CK if developed myalgia, and liver.
Okay, thank you.
Okay, my friends, are you ready for the case? نمتوا ولا ايه؟
لا احنا تعبنا مش
تعبتوا ايه يا عم؟ عايزين تقفوا؟ انا بقول نكمل.
It is okay, sir. It's okay. You can
Would
complete.
you like to continue or okay, we can go for a poll if you want. A, we would like to continue. B, we would like to go to sleep. We have two options, A and B. في اتنين عايزين يناموا. مين بقى دول؟ Okay, so we're going to continue, guys. Okay, I think we have about 30 minutes, okay? We can, yes, we can survive. We can survive, we can do it. Okay. Okay. So case scenario. ML, 37 years old female, has presented herself to your pharmacy with a new prescription of amlodipine 5 milligrams. Half tablets once daily for 7 days, then 1 tablet every day. She had mainly suffered since 2 years from resistant blood pressure, for which her treating physician had made previously several drug attempts. Below is the past therapeutic history of ML and reason of discontinuation. So she tried thiazides like hydrochlorothiazides and indapamide, and she developed intolerable side effects like dizziness, hypotension, and fatigue with both. And she tried ACE inhibitors like olmesartan, and it was ineffective, and fosinopril, and it gave her like severe cough. Afterwards, she tried ARPs like candesartan and gave her intolerable side effects like nausea, dizziness, and hypotension. And then it took an attempt with with calcium channel blocker like verapamil, and it was ineffective. And diltiazem, she developed allergic reactions. حظها فقر. Her last blood pressure reading was, yes, this is the last reading, 145/89. Heart rate 103. Potassium 4.2. Serum create 0.9. Current medications in her file are irbesartan 300 milligrams once daily, and it's tolerable. It's well tolerated. Celecoxib 100 milligrams twice daily when needed. ML is allergic to sulfa, penicillin, and peanuts. Type 1 allergy. Okay, is it clear? So this is the scenario. You can take your notes and we will proceed. اوكي تمام، يلا بروسيد. تمام، خلصنا النوتس. السؤال الأول question 1. Okay, 8 days later you called ML for a follow-up. she told you that she didn't take her morning dose of amlodipine 5 because of the headache, hypotension, hot flashes, and all-day fatigue she has been feeling since she increased the dose. What would be your best action? Number A. Tell her to take it before bedtime and to continue taking the 5 milligrams as planned tomorrow. If no improvement felt, then she can discontinue the medication. Number B. Advise her. What is it, guys? Yes, it's not that. Sorry. Okay, here it is. Number B, advise her that these symptoms are side effects that will fade out with continuous use of amlodipine. Number C, counsel her to return to 2.5 milligrams and not to increase to 5 till you reach out with the doctor. Number D, ask her to visit nearest emergency department for assessment. What do you think? Mm-hmm. Okay, we have 12 answers. Okay, let's answer, my friends. We need a 20. We need 20 answers. ما تجاوبوا يا دكاترة، فين الناس؟ Where are the pharmacists? Answer, pharmacist. Yes. Okay, 17. Mm-hmm. Do we have more? 18? Okay, that's fine. Okay, let's end it. Okay, most of you choose number C. Counsel here to return to 2.5 and not to increase to 5 milligram till you reach out with her doctor. Okay. Okay, why it's not A? Why it's not B? Why?
Can I
For what?
answer?
Yes.
Why not A? Because now it is A. If it's taken 5 milligram at the bedtime, it will have orthostatic hypotension in the morning and falls.
Okay.
And in this case, this is maybe a reason to discontinue the medication, and is not recommended in this case to discontinue the calcium channel blocker.
Mm-hmm.
Number 2, why not B? Advise here that some side effect will fade out the continuation of the amlodipine as a calcium channel blocker. It has this side effect and also has edema can be developed after that, which is not subsidal. The only thing it is to reduce the dose to prevent this side effect. This cannot eliminate with the continuation of the drug because it is vasodilator drug. That's it.
Yes. Salam alaikum. And number C?
Number C is the answer.
Which one you choose?
I choose C.
Why, my friend?
Because now this side effect, it is dose related.
Okay.
That's
So
it. So if you decrease the dose and monitor it, if it is the blood pressure is controlled, so go with the low dose without the side effect.
ماشي. Okay, but this is that okay, 2.5, is that a therapeutic dose? Hmm?
No, it is an initial dose, but it means therapeutic if controls the symptoms.
So why you asked her to continue with 2.5?
Because of the side effect.
Okay, so but it's not therapeutic one.
I will monitor the blood pressure. If it is controlled, it is okay. Maybe it is controlled at 2.5.
Okay, my friend. The right answer lies here. Till you reach out with the doctor. If it's not mentioned here, this answer would be wrong. Okay, but here, like that, yes, it's correct. Because here it's risk benefit. Okay, it's risk benefit. Despite the fact that you are not following the instructions of the physician here, but here the benefit is outweighing the risk to continue with 2.5. If you asked her to continue with 5, she will not take the medication. Correct? She will not take it. So you will put her you will put her at a higher risk of hypertension. Okay? So the best, yes, you can take the 2.5 till I communicate with the physician and see what we can do. We can change it, we can adapt it, and etc. Okay? So the right answer is C. Yes.
لكن انا صح يا دكتور في حته ان السايد افكتس دي
Yes, it
الهايبوتنشن
will not
flashes,
subside.
it is dose related.
Yes, it's dose related, and it will not subside with continuous education, with
Yes.
education, with continuous administration.
And also, especially, I read yesterday about something about the amlodipine edema. About
Yes,
the
it's
amlodipine
very
edema.
common, by the way.
Yes, it is recommended to reduce the dose to reduce the edema. That's it.
Yes, correct. This is right. Correct. And it's
لا
common, by
اشتغل
the way, the edema, amlodipine edema is very common. It happens.
Yes, لا
It happens at the leg.
انا بعد ما اخلص هشتغل معاكم.
ايش يا عم؟
Doctor, but usually with medications that reduce, that causes orthostatic hypotension, we usually recommend to take it at night before bedtime.
Yes,
So
correct.
why don't we do that with the amlodipine?
Okay, because you have here, my friend, you have here other symptoms like hot flashes. Will that subside? What about the fatigue? Will that subside with the?
I think the fatigue, because she's taking it in the morning, so that's
It's all day fatigue. It's all day fatigue. Okay, she's very fatigued, and we have here headache as well. Okay, so we have other symptoms that will not subside even with sleep. Moreover, the patient is very sensitive to medications.
True.
Yeah. So you have a high risk. These patients will not tolerate this medication. You have, yes, so if you conclude, we have a conclusion about that. You just see the history, how many medications she took. Okay?
Yes, thank you. Got it.
Perfect. Question number 2. Let's go. For which vital sign, yes, for which vital sign reading would you most concerned to know in order to take a therapeutic decision? Is it body temperature? Is it systolic blood pressure? Is it diastolic blood pressure? Or is it heart rate? Which one is a concern to you now in this case? Would you like to have a look at the scenario once again?
Yes, please.
Doctor, I have a question related to the first question, please.
Yes.
So the patient supposed to take like for 7 days half a tablet, and on the day 8 she didn't took the one tablet, the 5 milligram.
Yes.
So that's mean she didn't try the 5 milligram.
No, she tried. She took it that 7 days after the dispensing. That means she tried the medication like 8 days. She took already 8 days, and for the 9th day you called her. This is
Okay.
the scenario. So it
Yeah.
should be like
So
that.
let's go for my main concern. So this like symptoms is not an urgent symptoms. So that because I choose D.
No, there's nothing urgent here. What's the problem? They are side effects. They are expected side effect from the amlodipine, correct? There is a red flag here. Can you see any red flag?
Like an all day fatigue, is it like have to worry about or should be fine?
No, it should be fine. This is normal. It's not so normal here, but yes, we will talk about that.
Okay.
I will let you know now. Okay.
Thank you.
Okay, but it's a good remark, by the way, if I. Okay, guys, are we done? Only 4? Oh my God. Only 4 answered? فين يا جماعة الانسرز يا جماعة؟ 7, yes, okay. 8, 10, 10, 11, 12, 13, 14. Yes, 20. يلا 20. هانت اهي. 18.
Okay.
19. يلا يا رمي اجاوب.
خلاص يا باشا حالا اهو، دقيقة واحدة بس، أنا جاوبت أهو خلاص أهو، يلا بس.
يلا بينا. Here you go. We are done. Great, got it. Russia. Was it normal side effect? Okay. So most of you choose D. You
No.
choose D. Heart rate. Why?
It's heart
ليه
rate.
دايما? Why?
It's heart rate.
Yes, why heart rate? Why you are concerned about the heart rate? Why
Okay,
not concerned about the blood temperature and systolic blood pressure, for example?
Okay, heart rate here, it is 103. Okay, now we have calcium channel blocker, and we have ACE inhibitor, and okay, so we have this heart rate before below 100, the first sign.
What is the first sign?
Okay, it's the first thing that here we must have, or we have to have, that the heart rate
You have
below,
to bring the heart rate down
below 100.
Okay, got it. Okay, so you mean the heart rate is higher than usual?
Yes, even she is with calcium channel blocker and with ACE inhibitor. How come?
How come, والنبي? Okay, correct. ماشي. This is the right answer actually. Heart rate. And here we should correlate this one with what Faid mentioned before. Faid mentioned what? She's suffering from all-day fatigue.
Yes.
Okay. This is a sign here, يا عم Faid. I told you I will answer you at the time. Okay. So here, the fatigue could be because of the increased, because of tachypnea. She could be tachypnic. She could be tachycardic. Okay, so fatigue here is a sign there is a problem in her respiration and her circulation as well. Okay, so heart rate, and here you have already, she has a high heart rate. So amlodipine was not the correct medication في الأساس. You get what I mean? Heart rate, amlodipine is working how it works. It works by vasodilating the vessels. It's dilating the vessels. So it will aggravate or exacerbate the heart rate, the increased already heart rate. Okay, so this could be a concern here. And with the fatigue as well, this could be like it's something worrisome. There is a problem here we should focus on. Okay, so the heart rate is the correct answer. Can you show the case, please? I'm sorry I'm late. It's okay, دلوقتي. Oh, there you go. Heart rate is 103, which is high. Okay. تمام. Okay. Number 3. Her treating physician called you in response to your last communication to him regarding ML. He decided to switch the amlodipine 5 milligrams to bisoprolol 2.5 once daily to be increased to 5 milligram every day if tolerated. What would be your recommendation here? Bisoprolol seems the best available choice for ML's condition. Propose continuing amlodipine for 4 to 8 weeks till it gives its full effect, then decide. C. Switching to a diuretic like spironolactone would better have outcome in ML's condition, as furosemide is not recommended because the patient is allergic to sulfa. Number D. Switch to nifedipine XL would be more tolerated than amlodipine. Answers. Give me answers. Oh, I have 4 answers equally distributed. What do you think, my friends? Are we done? 15. Oh, we have a huge difference here. It's really a tremendous one. It's a tremendous difference between A and the other answers. Why is that? Look at 17. Yes, one more answer.
يلا هوب اهو خلاص.
فأعطاها فين يا عم؟
اخر حاجه
في دي؟
لا ايه انا اخترت ايه
حتى أنت يا أرميا. ليه يا أرميا؟ أوكي.
انا عاوز بيتا بلوكر عشان يهدي الهارت ريت، يعني لان اولا النيفيديبين هيعمل ريفلكس تاكي كاردي، هي مش ناقصه.
So why not C?
انا فكرت في سي بس لقيتها ان هي يعني
هايبركاليميا عنده.
الله 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 على الناس المصحصحة.
انا ما قريتش كده. ماشي
أسقف لكم بصراحة. بصراحة عليكوا سقف عندي انتوا الاثنين، فايد وإيمي.
وانا ما فيش حاجه بعد كل ده. طيب
انت ما عرفتش يا عم، انت بتقول لي مش عارف ايه.
دكتور محمد، ليش نعطي سبايرولابتون احنا بالهايبرتنشن؟
ليه ما بنعطي ولا ليه بنعطي؟
ليه بنعطي يعني سبايرول؟
انا ما قلتش هنا بنعطي، انا بقول ليه ما بنعطيش. why not to give the spironolactone? It's not the right answer. The right answer, by the way, is A. Okay, bisoprolol seems the best available choice.
دكتور
Here,
معلش، ده 4.1 البوتاسيوم مش كتير يعني، هو بين 3.5 ل5.
yes, I know, I got it. But you have, she's taken irbesartan at what dose?
300.
Yes, 300. Okay, she's taken a very high dose. Moreover, here spironolactone. What's the benefit of spironolactone in hypertension?
Nothing, هو بس for heart failure.
It's not a huge. It's not a huge benefit. Yeah. Okay. So why we don't use the spironolactone? Because she's taken the highest dose of irbesartan.
اوكي، عشان هي بس الالرجيك تو سلفا هي اللي خلتني اختار سي، فبس عشان
Yes.
كده.
فدي كانت طعم كده، انا راميها لكم كده عشان الناس الطيبين اللي زيك كده يختاروها.
الله يخليك، شكرا. اكلته.
اللي ما بيعرفوش الخديعة. اوكي بس اوكي تمام. يبقى right answer is A. Bisoprolol, because we already يعني it's my fault. We answered this we answered this question in the question number 2. We said that we need to control the heart rate. That's why you go with bisoprolol. But bisoprolol, yes, it's the correct one. Okay. So number 4, question number 4. Let's go. Upon following up with her cardiologist, ML has performed an ECG that showed left ventricular hypertrophy. Which of the following drug classes is known for their least ability to reverse left ventricular hypertrophy in patients with hypertension? With the least ability to reverse left ventricular hypertrophy. Is it the diuretics, beta blockers, ACE inhibitors, calcium channel blockers? Which one with the least effect to reverse left ventricular hypertrophy? جاوبت؟ اوكي. كله روح على كالسيوم شانل بلوكر. اوكي. Okay, guys, we need 2 or 3 more answers. Okay, 70, one more answer. Yes, that's it. Okay, D, wrong. It's not the right one. It's not calcium channel blockers. Okay.
معناته ايه؟
This is very deceptive questions. This is very deceptive one. What do you say, Faid?
A?
No, it's B. Beta blockers. ACE inhibitors and ARPs are the most medications that may cause the reversal for the left ventricular hypertrophy. Diuretics is the second, especially the spironolactones. Spironolactones is very important as well to reverse the remodeling of the left ventricle. Okay, calcium channel blockers, yes, especially the non-dihydropyridine. They can cause reversal in left ventricular hypertrophy. But beta blockers are the least. They are not controlling.
طب ازاي يا دكتور واحنا بنستعملها في الهارت فيلير؟
ماشي، وانا قلت لك لا. وانت بتستعملها ليه في الهارت فيلير؟ Why you use the beta blocker in the heart failure؟
يعني ما احنا عندنا عشان الهارت ريت.
لا، عشان نقلل الكاردياك اوتبوت.
بالظبط، عشان تقلل الجهد بتاع القلب.
طيب ماشي.
Okay.
انت حضرتك بتقول هنا ايه هما الليست ability to reverse.
Yes, reverse the remodeling. Have you ever heard about the remodeling? Have you heard about the remodeling of left ventricular?
مش كلمة reverse معناها يحافظ يعني.
No. Reverse يعني repair. When you have like for example sustained hypertension for a long period, your left ventricle will change in shape, will get thicker and like it will be thicker than normal.
مظبوط.
Be able to pump the blood with because your blood pressure is high, so you have a resistant vascular resistance. Okay, so the left ventricle will be thicker, the muscle will get bigger. When it gets bigger, your heart shape will be different than normal one. It will be different. Okay. This is what we mean by the remodeling of left ventricular. It's not as you said, it's not like preserving. انت قلت ايه؟ تحافظ عليها.
اوكي ماشي. يعني ده معنى كلمة reverse معناها انا هعمل ريموديلنج، يعني هعمل ريموديلنج، صح مش كده؟
لا you will be remodeling. هتعمل remodeling. You will repair the remodeling that happened. You will repair it. Okay.
Latest one beta blocker?
Beta, yes. And you have the answer. I got the answer here. Just one moment. Yes, here it is. A meta-analysis published in 2003 evaluated the relative efficacy of different antihypertensive drugs for their ability to reverse left ventricular hypertension. Here's the answer. ARPs, 30%. Relative reduction in left ventricular mass index. The most effective was ARPs. ACE inhibitors or calcium channel blockers, diuretics, and the least was beta blockers. After statistical adjustment to blood pressure reading, it mentioned here. No, okay. Okay, so it's beta blocker. ماشي? Clear? Number 5. Several months later, ML told you that she was diagnosed with heart failure and presented with dyspnea and fluid retention in her leg. Based on ML medical history, you would conclude which of the following. So she came today with dyspnea and diagnosis of heart failure and fluid retention. Okay, based on ML medical history, you would conclude which of the following. Number A, ML has been most likely diagnosed with heart failure with preserved ejection fraction, as she was suffering from left ventricular hypertrophy. Okay. Number B, left ventricular hypertrophy is most common cause of heart failure with reduced ejection fraction than heart failure with preserved ejection fraction. اللي هو systolic. We were calling them systolic and diastolic heart failure. Previous nomination for nomenclature for this condition. Systolic can reduced and diastolic was the preserved ejection fraction. Okay, number C, decompensated heart failure, as she presented symptoms of dyspnea and fluid retention. Number D, doesn't matter, as the treatment plan will be the same for all heart failure types. We have only 2 answers. Okay. Only 9 answers. يلا يا دكاترة، يلا عشان ننام. Hmm. 14. Okay, so let's go. Okay, my friends. No, it's not the right answer. Okay. Left ventricular hypertrophy usually is systolic or diastolic heart failure. If a patient has left ventricular hypertrophy, then we can assume that he will suffer from systolic or diastolic heart failure. Correct, Yarima. Correct, yeah, Iman. Systolic. Systolic means what? Reduced. It is a reduced ejection fraction. Okay? So the right answer is B. Left ventricular hypertrophy is more common cause of systolic or heart failure with reduced ejection fraction than heart failure with preserved ejection fraction. Okay? That's it. Is it clear? Okay, decompensated, the symptoms, by the way, the symptoms of dyspnea and fluid retention is the symptoms of any heart failure type. Either decompensated or compensated. You will find dyspnea and fluid retention. Okay? So number 6. Isn't decompensated is for the symptomatic heart failure too? Yes, it is. Correct. Symptomatic. Correct. نشرح لنا decompensated. Okay, decompensated means so YC is wrong. Decompensated heart failure presented symptoms of this because even she has guys, even if she has if she has a preserved ejection fraction heart failure, she will have dyspnea and will have fluid retention. Okay, decompensated means if the patient is taking the medication and the medication is cannot compensate the problem of her heart. Okay, what is the problem? Why the fluid retention happened and the dyspnea happens? Okay, because the heart cannot pump all the blood. There is a blood that goes back to the kidney, to the lungs, and the blood that not reaching the limbs, the legs. That's why the edema happens and fluid retention happens. If you are taking the medications will compensate the deficiency of your heart. If you are taking the medication and you are not compensating the deficiency, and there's still you feel symptoms, you have the dyspnea, and you have dyspnea and fluid retention, so you are in decompensation. What you have to do, you have to take another medications. You have to change the medication. You have to go increase the medications and follow the scheme for the heart failure treatment. As you know, we start by ACE or beta blocker, and then we increase according to the symptoms. Okay, that's it.
دكتور بليز الليفت فنتريكولار هايبرتروفي اللي هو او الهارت فيلر ريديوسد ايجكشن فراكشن، يعني السيستوليك هو بس اللي بيقل في اللحظه دي ولا؟
If it was left ventricular you mean?
نو مع الريديوسد حضرتك قلت ان هو سيستوليك هارت فيلر يعني.
Yes, correct.
يعني
What
يعني
is,
السيستوليك
my friend, what
يعني
is the,
السيستوليك
yes, I got your point. What is the ejection fraction? Ejection, what is the ejection? What does it mean, reduced
قوة
ejection fraction?
اقل من 40.
هو ايه بالظبط؟ What is it?
الايجكشن فراكشن اللي هو قوه دفع القلب للدم، قوه ضخ القلب للدم،
اللي هو كمية the quantity of the blood that goes out of the heart, correct?
بالظبط تمام.
Okay, so this is the answer. Systolic means when the blood when the heart systoles, when the heart pumps the blood out of the ventricle, there is a reduced, yes, there is a reduced quantity. It's not the normal. It's less than 40% of the blood that goes in the heart. Okay. So
والبريزرفد اللي هو
the blood can pump. The blood can pump. Yes, there is no problem in the systole. Systole, the blood can pump efficiently. Okay.
Thank you.
The problem is in diastole. The blood goes back from the ventricle to the atrium. This is the problem in the diastolic.
Okay.
Okay, my friends. Number 6. Clear? So far, so good? Yes. Here we have. Difference in therapy between patients with preserved and reduced heart failure is difference in therapy. ايه الفرق بينهم في العلاج؟ Number 8, digoxin showed decreased in morbidity only but not mortality in both groups. B, beta blockers and ACE inhibitors are used to reduce mortality in preserved heart rate through controlling hypertension. Beta blockers and ACE inhibitor are used to reduce mortality في preserved. Number C, there is no specific treatment for heart failure preserved ejection fraction due to absence of trial evidence. Number D, current management strategy of reduced ejection fraction heart failure should be based on an understanding of the underlying pathophysiologic process and managing risk factors. Okay, what is the answer? اوكي طب حد يدينا شوية جوابات كمان. Okay, 14 answers. Two more. 57% of the attendees. 57, okay, it's fine. Almost 60%. Okay. So you answered, most of you answered A, which is digoxin showed decrease in morbidity, but only, no, this is wrong. Digoxin, can we use digoxin in preserved heart failure? Was diastolic heart failure?
لا
ليه؟ Why? Why?
In heart failure, we use it in reduced heart failure, but not the preserved one.
Why? For what reason? How can we say that? مين زياد؟
نعم دكتور.
Sir, I think no, we can use it بس هو لأنه كاتبين morbidity only لأن هو morbidity and symptoms مش بس morbidity I think.
No. Digoxin usually we don't use it in preserved heart failure. What is the main job of digoxin, guys? How it works?
Rate control?
Huh?
Rate control?
Yes, it control it. Yes, it's work. It works with beta blockers to control the output and the heart effort or the heart output. But here there is also it works in the contractility of the heart. Okay, the one of the main jobs of the digoxin that it makes the heart pumps the blood in a higher quantity, if we can say that. Okay.
هو الديجوكسين ليه نيجاتيف انوتروبيك اند بوزيتيف كونتراكتيليتي فبالتالي ما اقدرش
positive chronotropic it's negative chronotropic and positive inotropic.
بالظبط.
Okay. Positive inotropic means it makes the blood pumps higher quantity of the blood. The make the heart pumps higher quantity of the blood. Okay, and here in diastolic we don't need that. There is no need for that. Okay, because the systole is very well. Systole is working very well in diastolic heart failure or preserved heart failure. Okay, some studies find that the digoxin may increase the mortality in preserved heart failure, or increase the symptoms. Okay, so the digoxin usually is not recommended in in the preserved heart failure, only in specific conditions like in atrial fibrillation, for example, or to control ventricular rhythm, etc. In the very specific situations, but usually it's not recommended in preserved heart failure. Okay, beta blocker and ACE inhibitor are used to reduce mortality through controlling hypertension. No, none of you answered that, and this is correct. No. Okay, they have no effect on mortality in preserved heart failure. There is no specific treatment. Yes, this is the correct one. This is the correct answer. There is no specific treatment for preserved heart failure due to absence of trial evidence. If you check the CTC, you will find that we treat the preserved heart failure with managing the underlying condition and reducing the risk factors and etc. And treat the symptoms. If there is symptoms, we treat the symptoms and etc. Okay, but there is no specific scheme, no specific algorithm to treat the preserved heart failure like the reduced ejection fraction heart failure. On the ejection reduced or the systolic heart failure, we know we should start with ACE and beta blocker, and then we increase the MRAs, the mineral receptor agonist, and etc. Okay, so there is a scheme, there is algorithm that we follow, but in preserved there is no scheme. Okay, is it clear? Number 7.
ده اخر سؤال ده ولا ايه؟
والله ما انا عارف، انا مش عارف الكيسه دي 9 اسئله باين. تعبتوا صح؟ طب يلا نخلص عشان دي بسرعه.
احنا جالنا هارت فيلير.
يلا انا بقول كفايه كده ولا ايه؟
يلا نحل اخر سؤال يعني.
طب يلا اخر سؤال. After ML's diagnosis with heart failure, what should be the target blood pressure to here? Yes. After ML's diagnosis with heart failure, What should be the target blood pressure? Oh, sorry. target blood pressure بتاعه المفروض يبقى كام؟ SB should be controlled below 120 ولا below 130 over 80 below 140 over 90 ولا 135 over 85. What is it? What is the answer? Hmm. احترس السؤال فيه خدعة. It's a tricky one. It's not that easy, huh? Okay. One more answer. Okay, we are done. Oh, we have two equal answers, A and C. What do you think? حد يقول لنا إجابة other than Armia. We need another volunteer other than Armia.
She is like, Amal is not a separate patient, separate criteria patient.
It's not sprint patient?
She is not separate.
Why?
She doesn't have chronic kidney disease, less than 75 years old, no Framingham score, and
Yes,
no.
but she has heart failure and hypertension.
Okay, so she's
a high risk. Is it a high risk or no?
Yes, she is.
So what's the target?
A.
No. It's not A. What's the answer? Any other explanation? Do you have any other explanation? Who can explain? Okay, let's go, my friend. Let's see here. High risk is defined as, this is a sprint criteria, okay? High risk is defined as 75 years patient, clinical, subclinical cardiovascular disease, chronic kidney disease, estimated Framingham above 15, okay? All of this criteria, the patient will belong to sprint criteria, which is the target below 120 for the systolic. But we have some exclusion. We exclude from sprint the patient with diabetes, with a stroke, history of heart failure, who were institutionalized. Exercise caution when generalizing result to this individual. So the heart failure is one of the excluded criteria from the sprint criteria. Is it clear? You got what I mean?
When I know, doctor, I think instead of heart failure, it's supposed to be hyperlipidemia. What I remember.
What do you mean?
So the excluded that you mentioned, or it's certain there, it's regarding to the intermediate risk patient. And should be, instead of heart failure, should be a hyperlipidemia patient.
But it's heart failure here.
Because heart failure, what I think, I'm not sure, related to the first criteria, clinical or subclinical cardiovascular disease.
I don't know. No, I don't think so, my friend. This is no. It's mentioned in the CTC and the up to date as well. If the patient with a history of heart failure, okay, so we can exclude him from the sprint. We're not following the 120 systolic blood pressure control. You meant the hypercholesteremia?
Yes, instead of heart failure.
From where did you get that?
CTC.
Really?
But let me check. Well, I'm sure like about 90% or maybe more, but maybe I'll check.
Yes, you can check, please. Because in my CTC, it's heart failure. Okay. So for my reference, it will be C. The answer will be C. Below 140 over 90. This lady is not diabetic, and she's not. She was excluded from the sprint. Okay, so we'll go for C. This will be the answer. Okay, guys. Okay, so it's slide 28. We have like 9 slides. And yes, we have some miscellaneous questions and some other questions. We can continue that next time.
Doctor, what about the hair Framingham risk score?
Melo.
Because he is hypertension and has what about hair Framingham risk
70,
score?
you mean 70? Because Framingham is 17. Hello? حد سامعني؟
نعم.
وراح فين
ايه يا
دكتور؟
دكتور، ايه يا دكتور انا معاك.
ومين اللي كان بيتكلم؟ مين اللي كان بيسأل؟
ده ديفيد، ده واحد اسمه ديفيد.
وراح فين؟
ما اعرفش، ممكن يكون الكونكشن عنده قطع.
اوكي.
انا عارف، هو صاحبي يعني، انا اعرفه.
تمام، اوكي. هو كان بيسأل على الفرامنجهام سكور، كوريكت؟
حضرتك قول لي الاجابه وانا هوصلها له، هو هيكلمني
طيب
بقى.
هو الإجابة، بص عشان هنا في حسب الاكسكلوجن you will find that the excluded the patient with this medical conditions were excluded from the sprint criteria. What are the medical conditions? Diabetes, stroke, heart failure, and institutionalization. I don't know what. So heart failure is one of the excluded patients from the target 120. You get what I mean? So the patient.
طب معلش يا دكتور، هي معناها ايه كلينيكال وسب كلينيكال كارديو فاسكولار؟ يعني كلينيكال كارديو فاسكولار ديزيز عرفناه، ايه السب كلينيكال؟
سب كلينيكال ما عندوش أعراض منها. It's not symptomatic. Subclinical disease.
يعني كل الكارديو فاسكولار ديزيز ما عدا الهارت فيلير. يعني يعني انجينا شغال، مايكاردال انفاركشن شغال، الحاجات دي.
Yes, but you have here, you have like exclusion criteria here. Okay, this is excluded from sprint, where any patient with these symptoms, you should exclude him from the criteria. For diabetes, you should follow the diabetes guidelines, like 130, below 130 or 130.
معلش يا دكتور.
Yes, sir, David.
معلش يا دكتور، انا كنت بسال 15 عشان هي هايبرتنشن وعشان عندها هارت فيلير، فتبقى من الكرايتيريا.
Yes, she's excluded from sprint criteria. She was excluded because she has heart failure. Correct? Okay, from sprint criteria. That's why we say the target should be 140 over 90, below 140 over 90. Okay. So we will stop here, my friends.
اوكي.
Okay. We will stop
دكتور
here.
بعد
Number
دكتور
7.
بعد اذنك ابقوا خبرونا بالمواعيد بدري، يعني احنا
ما انا مشير يا عم بتاع الجدول عندك. I will stop.
لا ما شوف ده انا اتفاجئت بالايميل النهارده الصبح، ما كنتش حتى كنت فاكره خدته السيشن.
ازاي خدنا السيشن يا عم؟ انت مش شايف؟
لا انا لان انا في ايميل جالي ان السيشن 10:30 الصبح.
ايوه بقى.